Neurosurgical Research Committee in Noramer. It's so great to see all of you here today with us. And now I'm going to present our dear guest speaker, Professor İhsan Solaroğlu. He is a well-known neurosurgeon whose career has primarily focused on neuro-oncology and neuroprotection, a significant number of presentations and citations. He has received many awards, such as the Professor Roja Award for Young Neurosurgeon and the AAC Young Neurosurgeon Award. As an active contributor to top scientific journals and founder of the IBNC, he played a pivotal role in the 2017 and 2019 WFNS World Congress of Neurosurgery. Currently, he is a lecturer, professor, and researcher at Koç University in Istanbul, as well as an adjunct professor at Loma Linda University School of Medicine in the USA. Before Professor starts, I wanted to add one last thing. In the end, we will take a photo together and we will have a question and answer session. And dear Professor Solaroğlu, thank you for giving us the opportunity to listen to you and learn from you. Your insights are invaluable to us. And thank you again for today's webinar. And I think we can start.
Thank you so much, Betül, for those nice words. If you will say, okay, I will stop my video and share my screen to make it faster for internet connection. At any time you can ask questions. Do not hesitate to ask questions. That's why I am here. And first of all, I would like to excuse for the last week because of the firewall of our institution. We couldn't make it well, but now we will compensate it, hopefully. Today, can you see my screen? Just a second. Is the host? Serhat, are you host? Because you have to able. Now currently I'm disabled.
Professor Noramer is the host.
I guess it's okay right now.
Okay.
Can you see the screen?
Yes.
Great. Just a second. I think it's working well right now, correct?
Yes.
Okay. Today I will give our experience in glioma surgery and give brief information about maximal safe resection. What does it mean, how we do it, and why we do it. But before that, I would like to give brief information about our university. As you know, Koç University is one of the top research universities in Turkey. When you compare with the other schools, other universities, we are relatively young in Turkey. Almost in the Koç University founded in 1993, so we are celebrating our 30 years. We have two campuses. This video shows the Rumeli Feneri campus, which is located in the northern part of Istanbul. We have also Topkapı campus, which is centered in the city center, dedicated for healthcare system. We are collaborating with more than 200 institutions in 40 different countries in terms of research, education, healthcare. So we are very keen to collaborate with other institutions, other researchers, other students. So I would like to invite all of you to come visit our university and become a part of any educational research and or other activities. As you know, glioma is the most common brain tumor and originates from glial cells. And it is repeatedly proven that the extent of resection is one of the most important predictors of overall survival, progression-free survival, and neurological outcome of the patient. So it means that whenever possible, you should remove as much as tumor from your patient. But it is not always possible. We will discuss about it and how we are managing this issue during the clinical practice. So the first thing is glioma is the most common form of brain tumors, and the extent of resection is quite important at the initial step of the treatment. This is a mainstream treatment for gliomas, not only for high-grade gliomas. As you know, we are grading gliomas in 4 different grades, starting from 1 to 4. Generally, it's accepted that the grade 1 and grade 2 are benign lesions, but may turn into grade 3 or 4, which are the malignant brain tumors. So even if it's grade 1 or 2, or 3 or 4, the surgery remains a mainstay treatment for gliomas. Before that, about the maximal safe resection or gliomas, we have to know about management of neurological disorders. As you know, understanding a neurological disease is a science. Diagnosing a neurological disease is a combination of science and experience. However, managing a neurological disease is an art. Now, during my talk, I will not tell about the surgical skills during a couple of hours in 1 square meter, in 1 centimeter square area, and operation is not an art. This is somehow skill, or it depends on training. But managing a neurological disease or managing a disease is an art part of the medicine. How we are selected patients for surgery. When we have an MRI or appointment with the patient, we have to discuss if there is non-surgical options for the treatment with the family or the patient. And again, the preparative discussion is quite important to emphasize goals and expectations during and after surgery, and again, to provide more realistic expectations from the surgery. So before the treatment or before the surgical approach, the goals must be clear and direct prior to entering the OR. So before any surgical intervention, we have to discuss all the details about surgery and expectations with the patient and patient family members. During the preparative planning, when we discuss about gross total resection, which means maximal safe resection, or flarectomy, or supra resection, supra-extended resection, so on, it decreases the percentage of recurrence or remnant part of the tumor. But on the other hand, when you aim to reach maximal safe resection or gross total resection, the complications which could be related with CSF or vascular or neuronal tissue damage can be increased. So we have to tailor the treatment according to the patient. Of course, during the last 20 years, advances in imaging provide a lot for us. Generally, this is an anatomical imaging of a patient on MRI. As you see here, this is the axial MRI, sagittal, and the coronal views. And easily you can see here on the left side, there's a tumor in the frontal lobe. And those are the FLAIR and T2 images, shows the brain edema around the tumor. This image is enough to decide whether this patient will need surgery or not. This is enough for decision making for surgery. But it is not, this is an anatomical imaging. But for preoperative planning, it's not enough. We need physiological imagings, and we are using in clinical practice very often. We are doing cerebral perfusion, MRIs, spectroscopy, just to know whether this is a tumor or this is another lesion, must be differentiated from tumor. And also we are doing mapping, and especially cerebral perfusion is quite important to have a target for the biopsy. For example, here, if you are not sure that whether this is a tumor or other kind of lesion, if you are planning to do at the initial step a biopsy from this lesion, so you can choose everywhere actually, anatomically. You can choose a biopsy from here, here, here, or here, or here. But how can you know that which part of the tumor or which part of the lesion will represent the certain diagnosis part? And that's why we are mapping the brain by using physiological imaging, cerebral blood volume, cerebral blood flow, and also spectroscopic MRI images, which calculates some components of the biochemical markers like choline or N-acetyl aspartate. And we are looking the ratios here. For example, if you look at the choline and NAA peaks, the CNI index we call is high in this patient, which shows a high-grade glioma. But if the CNI index is low, it shows this part will not represent the real diagnostic part of the tumor. Here is an example. Here you can see a tumor. So which part must be targeted to have a biopsy? There are hundreds of points that you can have a biopsy from this patient, but we are using cerebral blood volume, cerebral blood flow, and spectroscopy by using physiological imaging and having the best target for the diagnosis. On the other hand, what we are doing more before the operation, we are using functional MRIs. This is also physiological imaging. Here, for example, there is a lesion on the left side. Here we are mapping on the right side the motor cortex of the brain. Here another lesion. We are on the left side. We are mapping the functional areas around the tumor tissue. So it is not only for planning the surgical approach, but it is also important how to make safe resection. So when you are resecting the tumor from this border here, you have to be careful not to touch this area. Those information is also necessary to discuss with the patient or patient family regarding the mortality, morbidity rates, or risks of the surgery that you will perform. Another advances in imaging in subcortical white matter tracts by using diffusion tensor imagings. Here, DTI shows all the fibers going from the cortical cortex of the brain all the way go down to the brainstem and spinal cord. This is again important to plan the surgery and the surgical approach, but again, this is also predictable factor before the surgery that the expectations from surgery will be more clear. For example, if the lesion in this region, you can easily look at the fiber tracts, whether they are disrupted or they are compressed. If they are only compressed but not disrupted, then when you remove the tumor, when you do the decompression from the fiber tracts, this patient will have benefit from the surgery, and his or her neurological conditions can improve. But if the lesion is disrupted those fiber tracks, it means that the aim of the surgery will not recover from the neurological deficits or any benefit from neurological deficits, but it is important to decrease the intracranial pressure or decrease the volume of the tumor or malignant tissue in the brain. So it is important not only for the surgical planning, but also predicting of the outcome after surgery. Here, and you can combine all those informations together. Here, there's a deep-seated lesion, which is important and which is very close to the functional areas. Here, you can map the functional areas, all the fiber tracts, and choose the best way to remove this tumor and choose the best and safe approach to remove the tumor. Why those are important? Why we are evaluating, especially in glioma patients? Because even in grade 4 tumors, when you look at the MRI magnetic source imaging findings, there is still 8% functional areas within the tumor and almost 15% at margins. And especially in grade 2 tumors, it increases up to 20%. So the surgical decision and the aim of the surgery must be previously described before the operation. So we have to tailor case by case. We have to evaluate all information coming from those physiological imagings and then tailor the surgical treatment according to the patient. During the intraoperative stage, we are using other advanced technologies like neuronavigation here, or intraoperative MRI, or intraoperative ultrasound, or 3D or 2D, 3D fluorescence guided surgery. We are using a lot during our clinical practice. Those are the intraoperative technologies that we are using during the surgery. Especially during the last 10 years, fluorescein-guided neurosurgery became popular in glioma surgery. We do not have commercially available 5-ALA in Turkey, but we have fluorescein sodium. So that's why I do not have enough experience with 5-ALA, which is expensive and not available in Turkey, but I have a lot experience with fluorescein sodium guided surgery in gliomas. Actually, fluorescein sodium was founded almost 100 years ago, more than 100 years ago by Adolf von Baeyer, and used to discriminate or discriminate of normal tissue and the tumor tissue in GI surgery with high doses. But now, 100 years after, we are using fluorescein sodium guided surgery to remove the glial tumors. Actually, if you have a microscope, dedicated microscope, which has different kind of filters, you will be able to differentiate the normal brain tissue and the tumor tissue when you switch from the white light to the dedicated yellow filter. I will show you an example. The main difference between 5-ALA and the fluorescein sodium is the mechanism of enhancement of the tumor. While 5-ALA is metabolized in the tumor tissue, fluorescein sodium accumulates in the areas with disrupted blood-brain barrier. Here is an example. There's a tumor on the left side, in the temporal lobe, and a huge tumor, and those spectroscopies showing CNA index is so high, which shows us or tells us this is a high-grade glioma. This is the temporal lobe on the left side. It's a frontal lobe, temporal lobe, ciliary fissure. We are expecting to have the tumor here, but to reach this tumor and its core, you have to cut or make an incision normal brain tissue. So you can reach to this tumor from this side, this side, this side, this side. There are a lot of opportunities. This is my microscope under the white light. Here, oops, so sorry for that. This is my microscope view under the white light. When I turn the filter, when I give 2 cc's sodium fluorescein intravenously to the patient, now you see what will happen. This is under white light. Okay, so you can easily see the thinnest part of the cortex. And that's why I'm doing the cortical incision from the thinnest part and starting to remove the tumor under the white light. And at the end of the surgery, I thought that the tumor is finished and all the borders are clean. But when I change the filter, here you can see easily, let me show you again. Okay, here you can see the remnant part of the tumor. And then I'm changing the filter to the white again and completing the surgical resection of the remnant part of the tumor. So those are very helpful techniques that you can use intraoperatively. While we are doing surgeries or while we are doing our job, we are also running a lot of research projects. And we are collecting all the tumor tissues for our research purposes. What we learned so far, if you are removing a tumor for your research center, and if you are doing the surgery under the under the sodium fluorescein guided surgery, you have to take the biopsy before giving the sodium fluorescein. Otherwise, those sodium fluorescein guided, when you do the biopsy under the sodium fluorescein, it inhibits proliferation and sphere formation of the primer cell cultures. So that's why before giving the sodium fluorescein, you have to take some part of the tumor and send it to the research laboratory and continue your surgery with sodium fluorescein. It's better. And we recently published it in Brain and Spine. And Serdar is one of our fellow, came to us for his thesis. So it's our addition to the literature, and this is the first publication related with this issue. I will show you in case by case, step by step, and I will again show you what we are using in different manners during the surgery. Here you can see on the left side there's a tumor. What we did before the surgery, we mapped the we mapped the speech area here, functional MRI, and this is the motor cortex. Here, the lesion is in between the speech center and the functional cortex, motor cortex. And again, this lesion compresses the fiber tracts, and the best option to go into this tumor is approaching from this side. And while we are resecting the tumor from this part, we have to be very careful on the back side and the front side, because it's just in between the motor cortex and the speech center. This is step by step this is neuronavigation system. What does it mean? Let me give an example, very simple example. Think that the brain is the map of the city, and the tumor is the building that we want to go. And we are putting all this map to the neuronavigation system, uploading this, and then all tools that we have in our hand is the cars or the machines that we are using in the city. And before any skin incision, we will be able to note the borders of the tumor, the point of entrance, and the skin incision, and the motor cortical areas, just by using this neuronavigation system. And then we are putting some electrodes to have real-time intraoperative monitoring, which is the best technique that shows the direct evidence of the functional areas, neurophysiological recording and real-time monitoring. When we do the craniotomy, you cannot differentiate the tumor between the normal brain tissue and the tumor tissue with your only with your eyes. Here you can see. And then what we are doing, again, by neuronavigation system, we are checking out the borders of the tumor. And we are starting using the neuromonitoring system, giving some impulses from the cortical surfaces to map where is the shoulder, where is the hand, where is the leg, where is the mouth, whatever. And then we are putting and mapping the places. After that, we are using electrodes to have continuous monitoring during the surgery, which shows us here, for example, right thumb, right oris, right deltoid, right biceps, right rectus femoris, right tibialis anterior, so on. And continuously we can monitor those functional areas, whether they are affected or will be affected during the surgery. Again, intraoperative ultrasound is quite a helpful device to show the borders of the tumor, as you see here. What we did so far, we used neuronavigation system. We used neuronavigation system not only for the craniotomy, but also for detecting the location of the tumor. We used mapping and also putting electrodes to map the cortical surface, and ultrasound to be sure that the lesion is at this point. And then we started resection of the tumor, and again, we are able to perform to subcortical neuromonitorization. And subcortical, we can have the subcortical waves during the surgery, which shows us where is the functional area, how close we are to functional areas, and where and how to stop during the surgery. Now, I will show you an example of case. Here we are using neuronavigation system to see the borders, and then starting the coagulation. Oh, sorry, what happened? And we started to coagulate the arachnoid membrane, preserving the anterior part and the posterior part of the venous system at the cortical area. And I know that this is the entrance point. Now I'm cutting the arachnoid membrane with a needle. And with micro scissors, I'm cutting the cortex and at the same time the arachnoid, and here with the dissector and suction, I can easily, I found a cleavage. Now I'm dissecting the tumor until I will be able to reach the normal tissue here. Generally, tumor is elastic, but here you can see the white matter. And here, maybe the high-grade part of the tumor, the color is changed. And after resection of the tumor, here, let me skip fast. Here, we are removing the tumor. Again, we are using intraoperative neuromonitorization, giving this stimulus to the subcortical areas and removing the remnant part of the tumor. Here, and it's done. So this is the postoperative images. Here you can see the tumor is almost removed. This is very early period of the surgery, after the surgery. That's why you can see the blood around the surgical area and surgical walls in the brain tissue. But here you can see the tumor is almost completely removed. Of course, as you know, especially in high-grade gliomas, almost 100% of cases will recur within 2 years after the initial treatment. Even you perform chemotherapy, radiation therapy, or gross total resection. This is an example. It's a frontal lobe high-grade glioma. What we did here, you can see the frontal left frontal operation site. There's no tumor, nothing after 18 months. Again, here you will see huge cavity, resection cavity. We did an hyperresection or extended resection in this patient. Nothing in 18 months after the surgery. But look at this. 36 months after surgery, as you know, especially in high-grade gliomas, the prediction for overall survival is around 14 months. Or then 36 months is very nice follow-up period for this high-grade gliomas. And here, at 36 months, which means 3 years after the initial surgeries, there is nothing on the operation site. Here, huge cavity in the frontal lobe. But look at this. Oops, just let me show you something. Here, there is another lesion on the opposite side, on the right side. And this is the video of during the operation. Here you can see we have the huge cavity, we resected tumor. Nothing in 18 months, but after 36 months, there is nothing on the operation site, but there is a recurrence on the opposite side. Why I am telling this? So we have to know a lot about gliomas and the biology of the gliomas, because otherwise we cannot able to have a real cure for those patients. And even during the last 30 years, advances in radiology, advances in anesthesiology, oncology, neurosurgery, microneurosurgery, we couldn't add more than 2 months to those patients in terms of overall survival rates. So that's why we have to know more about gliomas. And we have to work and continue to research and help the researchers to create more new, to create more data regarding the novel treatment strategies in gliomas. This is the keynote, regardless of her or his level of competency and field of specialization. Gliomas are not diseases that can be treated by a single physician or surgeon. Interdisciplinarity is essential to find a new treatments, to do your best and find new treatment opportunities for those patients. That's why we are collaborating with Koç University Research Center for Translation Medicine at our institution as a neurosurgery department. But on the other hand, KUTTAM is funded by me. So far, I received more than $10 million for my research projects, and I founded the KUTTAM Research Center. It's not dedicated only for neurosurgery, but in all fields of translational research in medicine, including social sciences, life sciences, and engineering. So sorry. There are currently more than 9,000 square meters areas is dedicated for KUTTAM at Koç University, distributed into 2 campuses, and more than 300 researchers, including PhD students, postgraduate students, or academic members, are running their research under the umbrella of KUTTAM. And when we look at the glioma research related with KUTTAM, every year we are publishing many high impact papers in literature, and always you have a chance to join us and have a part of this research projects. What we are trying to do, just last couple of last slides, what we are trying to do right now is, one of my PhD students she's in Stanford right now, will be back in next year in Turkey. We designed and created a microscope without labeling with 5-ALA or sodium fluorescein. Hopefully we will able to differentiate the normal brain tissue and the tumor tissue by using this Raman-based artificial intelligence dependent new microscope within a couple of years. As I told you before, interdisciplinarity, teamwork is quite important for your success as a medical doctor, or as a researcher, or as a neurosurgeon. And we are all, we know that our team members in clinical practice includes oncologists, neurologists, radiologists, pathologists, even dietitians or physiotherapists, nurses. But in the near future, our new team members will be changed, or the new team members will be added to the team. What will be our new team members? Of course, AI or machine learning, deep learning will be our new members to decide whether to operate or not operate, or when operate or why operate, and explain to the patient and the family members, and also as a neurosurgeon to yourself. There will be another tools that we will be using in our clinical practice, and those tools will be dependent on big data. We all discuss about big data for the last 10 years. And again, machine learning, deep learning, Internet of Things, we are discussing about it. But what does big data mean? When I read an article that's published in I guess 2015, how big data will be in 2025. Let me give you an example. As you know, astronomy is one of the main core that providing data from galaxies, from stars. And it's predicted that in 2025, every year, 1 exabyte data will be coming from astronomy. On the other hand, two big social platforms, at least for now, YouTube and Twitter, will provide every year 1 to 2 exabyte data. But when you look at the genomics only, it will provide 2 to 40 exabyte data per year. So as I'm 52 years old, of course I know about bytes, kilobytes, megabytes, gigabytes, nowadays terabytes, but I am not aware what does exabyte means. And I look at that, and I learned that 5 exabytes is equal all the words ever spoken by human beings. Now you can imagine that only in 2025, genomics, which is related with the healthcare or health research, will provide 2 to 40 exabyte data per year, which is almost 20 times bigger than YouTube, and 5 exabytes is equal all the words even spoken by human beings. It is really huge data. And for the next century or for the next couple of 10 years, you have to be ready for this disruptive and groundbreaking era of the medical research and medical practice. And those are the team members, Tuğba Hocam and Mehmet Hocam. This is the engineering part, this is the basic science part, this is the clinical part, and all our collaborators and our institutions that we had funding from so far. And again, thank you for this opportunity. You can always send me an emails. You can always contact with me. I always respond, but it does not mean I will respond within a couple of days. Sometimes it takes weeks. But again, thank you for your patience during my talk. If you have questions, I would like to happy to try to answer.
Thank you, Professor, for this presentation. It was very informative and enlightening. So if you have any questions, you can ask it on the chat. Professor, I think
there is no question.
I think we have a question.
Sure.
Yes, someone said, how about oncolytic viruses? Have you worked on them in glioblastoma? How successful was that? I guess the question is.
Actually, there are many clinical trials related with the. You asked the oncolytic viruses that will be resulting glioblastoma in clinical cases, or treatment of glioblastoma with the viruses. There is two different very young.
No treatment, I guess. It's in the chat box. There is a question.
So far there is no direct evidence that shows the oncolytic viruses results in or is the main reason for glioblastoma. There is no direct evidence about it. There are many research run before, but there is no direct evidence for this. But on the other, there is another topic that we can discuss. Some viruses could be used for the treatment of glioblastoma, but still, hundreds of research, clinical trials did not provide any benefit to the patients during the last 20 years.
Okay, thank you. And there's another question. I would like to ask the cost effectiveness of intraoperative MRI. Do you generally use this technique?
Okay, it's not cost effective, actually. It's because when you are when you have an intraoperative MRI, you have to all the setup which must be MR compatible. And of course, the other point is how glioma volume you have in your institutions. If you are operating 10 or 15 gliomas per year, having an intraoperative MRI makes no sense. So the cost effectiveness is depending the number of cases that you are doing in your center. Again, intraoperative MRI is time consuming and expensive technology. That's why generally centers that using intraoperative MRI are using the same MRI for outpatient clinic and outpatient investigations. But at the same time, they are giving an appointment for the OR unit. So you can move the MRI to OR, or you can move the patient to the MRI. So you have those systems, and which is quite expensive. But we do not have, at least for now. But it's a fancy tool. If in the future I will have an intraoperative MRI, of course I will be happy to use it. But it is difficult to say it's cost effective.
Okay. And we have another question. Someone said, could you please elaborate on okay, I can't say it. Okay. MR and
so
its advantages
in MRI and
yes.
advantages in preoperative planning of
yes,
okay.
Exactly.
Especially when you spectroscopy MRI shows us whether this is okay. There are a couple of aims that you are using spectroscopy. First, if you have a lesion, and if you are trying to find the best target for biopsy, this will help you, because when you look at the levels of some colon peaks or NAA peaks, where it is higher, that you should take the biopsy from this part, because it shows it represents the tumor. On the other hand, we are using spectroscopy to differentiate a recurrence of the tumor or radiation necrosis. Because in the standard treatment of gliomas, when we do surgery, after that, generally, a month, 15 days, radiation therapy and temozolomide therapy is standard treatment. A couple of months or weeks after the radiation treatment, we can see radiation necrosis on MRI scans. To differentiate, in contrast enhanced MRIs, it is same like tumor or radiation necrosis. It looks like same. To differentiate it, we are using MRI spectroscopy and also MRI perfusion. If there is no perfusion and the CNA index is decreased, it shows this is radiation necrosis. You don't need to operate again. But if there is CNA index is high and the cerebral blood volume in the tissue or cerebral blood flow is high in this contrast enhanced area, it shows us this is a recurrence of the tumor or remnant of part of the tumor. So that's why just not for preoperative planning, but also for follow-up period, spectroscopy is quite important for us.
Thank you, Professor. So we have a lot of questions, I guess. Someone said, can you explain a bit tumor vaccines do they use for gliomas and can they be effective?
I believe in the near future, vaccines will be in our life. You might know I'm the founder of Clinical Trials Unit at Koç University. And a couple of months ago, we signed an agreement with BioNTech to run vaccines to treat some certain kinds of cancer in our institution as a clinical trial, of course. I believe it will be a hot topic in the next 10 years. But do not forget, those vaccines are different than the vaccines that we know. You know, we are using vaccines to protect ourselves from certain types of diseases, but such kind of vaccines are for the treatment, not to protect. Okay? So there is a differentiation. There is a difference between the terminology. I think there are a couple of clinical trials, not couple, maybe more than 10 or 20 clinical trials related with the vaccines in the treatment of gliomas. But still, as I told you before, we do not have direct evidence or any cure for the treatment of gliomas so far, unfortunately. Can you name some main reasons
that sounds like an interesting topic.
Unfortunately, Siavash Azizi, unfortunately, we don't know. There is, of course, genetic, how can I say, some genetic problems are related with the gliomas, but in common, we don't know. We don't know, unfortunately. If we will know, then we can cure. What about techniques of increasing permeability like FAST or ultrasound where they are more successful and commercially available? Okay, especially for, you know, there's a blood-brain barrier and it restricts the passage of some treatments from the blood to the brain tissue. We know that. Especially a couple of groups from ETH, I know them very well, or in other European countries and US, they are trying to use ultrasound to open the blood-brain barrier and give a chance to pass those new treatments to the brain tissue. Okay, the initial results looks at, especially in the in vitro and in animal studies, it works well, but still we do not have enough data to put those in the standard treatment of glioblastoma. Is gene therapy currently used in glioma treatment? Unfortunately not, because glioblastoma is like a solid tumor. We are not using CAR T cells. It is not possible right now, for example, in multiple myeloma or lymphomas. CAR T cells are very critical and important treatments, but in solid tumors, we are not able to reach the glioma cells by using CAR T cells or other kind of cellular treatments yet, but there are many groups working on that, including us. Can you use endovascular approaches in resecting some tumors? No, not for resecting the tumor, but to enable it more easier. For example, if there's a huge skull-base meningioma, you can, if the feeders of the meningioma is many, and which means that your bleeding during the operation will be much, and it will be difficult to remove. Then before the operation, you can use endovascular treatments to obliterate the feeding vessels of the tumor, make it easier during the surgery. I only had a question. I really hope it isn't simple, but does the patient experience any unexplained loss of motor function? Of course. You can have it, because except intraoperative neuromonitorization, subcortical or cortical mapping, all the other techniques like functional MRI, neuronavigation, and others are not 100% true. So 70%, 80%, 90%, it's okay. But still, you do not have 100 certain data about your patient. Just we are trying to decrease the chance of the morbidity. But still, there is a chance for morbidity or unexplained neurological deterioration. You can do the surgery very well, but after the surgery, you can have a hematoma in the surgical site, which can compress the functional areas, and this patient can experience neurological deficits after the surgery. So risk is always there. So you have to handle it. Okay, further staging of the tumor. Actually, in 2016, the World Health Organization changed the description of the stages of brain tumors. And now, genomics are very important. And some genetic changes change the diagnosis of the tumor. And it is really difficult to imagine what will happen within 10 years. So what technology is used for this? The genomics is currently very popular to describe, or staging, not the staging, but the diagnosing of the tumor. Thank you for your presentation. Thank you. That's all. Yeah, I do not have any other questions. Correct, Betty?
Yes, I think that was all. And thank you again, Professor. And I think we have another question. Someone said, can we direct stem cell differentiation and implant them into the damaged or degenerated areas of the brain? Is there such a therapy currently, and is surgery used in it?
Okay. So far, there is no direct evidence that stem cell therapy is beneficial in regenerating of the tissues, especially spinal cord or brain tissue. But there are a lot of clinical trials trying to show the initial step, phase 1, which means that these treatments are safe. Phase 1 shows us this is safe, but it does not mean it provides benefit. Now, there are other studies trying to show whether the stem cell treatments have benefits on stroke patients, or in spinal cord injured patients, or degenerated areas of the brain. There are a lot of trials running by different institutions, and hopefully 2024, at the beginning of 2024, we will start a phase 1 clinical trial with Mayo Clinic and Koç University Department of Neurosurgery, stem cell treatment in spinal cord injury patients as a phase 1 trial, clinical trial. Just at the beginning, we want to show the safety of the trial, the safety of the treatment, and then we will look at the benefits of the treatment. Currently, there is no study showing the directly benefit of stem cell treatment. Okay, that's why.
Okay, thank you.
Yeah, there are many centers that providing stem cells. They are doing stem cells. They are treating with stem cells. Blah blah blah blah blah. But to be honest, sometimes they are abusing the patient. So you have to be very careful.
We have another question. Can we use hormone replacement therapy because some research shows us some hormones also cause formation of tumors? Is it effective or not?
Leila, I don't know what tumors that you mean with the hormones also cause formation of tumors. Okay, for example, in meningiomas, which is the most common benign tumor of central nervous system, meningiomas mostly depend estrogen in female patients, and after the menopause, those tumors are not growing. But it does not mean we have to remove the all estrogen from the body, you know. But we know that, especially in breast cancer, there are hormone-active tumors or prostate tumors. You can use hormonal treatments, or you can replace or withdraw the hormones from the system to have a cure. But in gliomas, there's nothing related with this hormones and treatments or protecting the body from tumors in gliomas, unfortunately.
I think that was all. We don't have anything else to ask, I guess. Yes. Thank you, Professor, for everything and for this presentation. And thank you for your valuable time. Thank you for agreeing on giving us a presentation. And I think if we can turn on the camera, we can take a picture. Yes, thank you so much again for your time and for this informative webinar. And yeah, I think we can end this webinar.
Thank you so much to you, because today is I guess Wednesday, correct?
Yes.
Yeah, and 8 o'clock or 9 o'clock. I'm still at the hospital. It's not a problem for me, but it is really difficult to find 30 students at this time. It's not a weekend. Probably you have a lot of things to do. You have to study or work for tomorrow, or you may have examinations in the upcoming day. So thank you for listening me. And as I told you, you can always reach to me by emails, and see you somewhere in the world.
Thank you so much. And good evening.
So much. Good evening.